And it reminded me particularly of faculty work and what you guys are teaching, and that you're in that atmosphere many, many hours during the semester. So I wanted to just come and overview it with you because I thought it was pretty good information. So thanks for being here, Miss Julia, and welcome to BHCLR.
Well, thank y'all for having me. I'm very privileged to be here and talk to you about patient safety. We have a lot of things that are going on as a result of some work that was done in late 2016. It was really our first year that we had electronic reporting for incidents or occurrences that occurred in the hospital setting. And so in 2016, I was able to put together an annual summary to show our leadership where we were in baseline and where we really are trying to go. We set some goals at that time, basically because we were trying to determine how far we were able to proceed. We'd already had a major improvement in reporting and usage with our quality assurance communication reporting system, lovingly called Quackers. And I don't know if you have seen that, but in the medical record on the banner, there is a Quackers icon where staff, physicians, students can click and report an event, a near miss or an occurrence, either personally or anonymously. So we really had a lot of great achievement in that first year, regardless of where we wanted to go in the future. But in the end of 2016, I was tasked with defining some goals for our organization. Senior leadership has never historically sat and heard all of the things that are occurring in the hospital setting from my department. Historically, we would bring all the great things we were doing to try to improve on things, but to sit and listen to the almost certainly preventable events that occurred in our organization really heightened their awareness and their desire to change some of the things that were happening in the organization. So it was actually very scary for me, as well as rewarding to see that response. And Troy Wells just said this needs to be on the top of the agenda for our system to not harm one of our patients. So Bob Roberts and myself were tasked with implementing an effective patient safety program. We've always had one defined in our risk management patient safety plan, but to bring about change in the organization so that we were actively working towards improvement was the goal that we really set out to do in 2017. So our current focus was really defined to set about what we needed to do for leader rounding and huddle topic coordination. How do we address patient safety facility committee meetings and actions, engaging our physicians in our patient safety program, and identifying champions within our organization that were really doing a great job in reporting on patient safety. And finally, and the one I think is really the most important, it's not low-hanging fruit, it's the hard work of changing culture, is progressing towards a just culture and non-punitive response to events. Communication, as you know, is really the basis of most misunderstandings as well as root cause. When we have events that occur within our organization, more often than not, there's some type of communication failure within either a handoff situation or one discipline to another. So we wanted to try to communicate to the organization our goals, specifically where we wanted to go. We picked I felt like an achievable goal. We had no idea really because we had never worked on this, but we wanted to increase our reporting by 10% across the system. And the information that you see before you is as of the end of the second quarter. We achieved that goal before the end of the second quarter by an increase of 53%. It's somewhere around 57% now. And I believe a lot of that had to do with the awareness of our leadership being driven by our senior teams and stating that there's going to be some accountability for reaching these goals. So just the awareness of what we were trying to achieve and review of this information on a monthly basis with that team has really supported the initiative. On top of that, our administration was educating our own staff when they went out and did legal roundings to report things via Quackers. So when they were being told what their issues were on the units, the administrator would ask, did you report this in Quackers? And if the answer was no, they showed them how to do that, which was really a neat incentive. And then just increasing the awareness and understanding of how reporting provides us with really great information about how to improve our processes that will help to improve care to our patients. Most events are not people related. It's a process failure that allows that to occur, and it ends up in an event involving our staff and patients. The second goal that we had was to increase near miss reporting. And we had to really start with what is a near miss, because there were a lot of individuals that didn't understand what we meant. A near miss is basically those kinds of events that we identify as providers and care providers whenever we are delivering care, and we fix it before that event actually reaches the patient. Maybe it's a wrong dose that was dispensed from the pharmacy, or perhaps it was an expired medication or an order that was meant for a different patient. All of those things potentially could be a near miss report. Well, as of the end of June, we had met this goal by 505%. We participated with the state with a near miss campaign, and so they were wanting us to set a new goal, and I said back to them, how do you set a goal over 500% improvement? We are currently at 1,000% at this time. So I'm really excited about our near miss reporting progress. All of that had to do with the education on why we needed near miss reports, the support by leadership and incentives to report. I think that day off with pay really helped us to get some near miss reporting done. And then the campaign itself led to some really good incentive for people to participate with us on near miss reporting. The next step in near miss reporting really is to place them into the same type of review that we would do with an event that occurred. So a critical event analysis or root cause analysis to determine how that event specifically could be addressed in a different way, perhaps with some engineering controls, so that it doesn't allow an event to actually occur and reach our patient. Part of our review from 2016 was meant to identify really what near miss themes did we see throughout the reporting, and surgical cancellations were the ones that continuously had some elements of near miss education and training and need that we decided to focus in on. Dr. Lingasetti is leading a Greenbelt project on that very topic to determine how we might be able to reduce the issues that surround surgical cancellation. That might not sound like a near miss, but when you think about the variation that occurs when you cancel a surgery, you've got staff involvement in that that's moved. Anesthesia is a great example of staff that are moved. They're assigned to a case and they're flipped to another room. They may not be familiar with that case, and they could in fact miss something very important. Think about the physician and the patient satisfaction. If you've taken off of work to take care of a surgery and something occurs and you can't have that surgery on that day, you're not going to be very happy with that situation. And then just in the efficiencies of the organization, there is so much dollar attachment to a surgical cancellation, both for the patient and for the organization. So we really felt like if we focused on surgical cancellation and found some of the root issues that we were identifying as an organization, that we would get a win-win on all sides between our staff, physicians, and our patients, potentially impacting our satisfaction scores as well. So that goal we blew out of the water. Near miss reporting went so well that ADN was wanting us to put together a presentation on how we worked as an organization to improve our near-miss reporting for potential presentation to Congress. On goal 3, we wanted to reduce the almost certainly preventable events. We looked at what our baseline was in 2016 and determined that those that were moderate harm or greater, we really wanted to focus in on those things because that was actually bringing harm to our patients. Two different elements really impacted this. One is, as an organization risk management team, we got better at consistency in identifying moderate, severe, and death cases. So we had criteria and meetings to go over those things to make sure that we were assigning them consistently the same across the system. But then secondly, we found that our early engagement with the individuals on the units when these things occurred allowed us to mitigate a lot of the damages that might actually have impacted the outcome for the patient and the severity of the event. And so early intervention and an interdisciplinary response, physician involvement and awareness in the care that was being provided at that time really did help us. We tried to empower staff and support them whenever they were being transparent about things that occurred. So really trying to reward behavior which says I made an error and this is how it happened or how I think it may have happened, to just be open with us so that we can learn from the events that were occurring. I'm proud to say that at the time of this, and we're on track still at about 54% at this time, that we've been able to decrease the harm that is coming to our patients at about 50%, 54% this quarter. The leadership rounding focus was really meant for that consistent tie throughout our system on what we're focusing in on as leadership. Stephen Webb was the champion, administrative champion, that was tasked with coming together with everyone on the interdisciplinary team and addressing the leadership focus per month. So 7 main safety elements were chosen to review with staff each month, 1 element per month. So you've seen that in the patient safety corner. Hopefully you've seen that every Monday, Wednesday, Friday, Saturday, Sunday. There's information in there specific to whatever that topic is. So we started in June with handoff communication because that seems to be one that we really need to keep working on as an organization. And then the leaders were asking those questions as they were rounding on their units. They were asking those questions. The nursing leadership were rounding on their units to address and observe handoff communications. So all of us working together between huddle, nurse leadership rounding, and then our administrative leader rounding was meant to consistently provide a focus on that safety topic while they rounded. We got some good feedback on that, and as we learned from it, those things were brought back to the senior leadership group on how are we going to try to address some of those things that our patient staff teams had brought forward. So we really are working for a consistency in the message across the system. Nursing leadership rounds were to address elements of patient care and treatment. And in discussing this with the System Nursing Council, we talked about adding a specific question to patient safety related to HCAHPS that perhaps they could focus on. We talked about in different areas that question may be different, but the organization as a whole, we're hoping to accumulate those findings and into a quarterly review and identify lessons learned and actions that we have taken in response to the findings. One of the really awesome outcomes this year, I think just specifically because of the focus that we had on patient safety overall, was that our patient safety culture survey had the most participation in the history of Baptist, especially in the last 6 years that I've been here. I was really satisfied to see that we had over 2,000 people that actually participated in the responses. Positive findings this year that really just thrilled my heart were that they started to see that we were actively working on improving patient safety and that our mistakes were leading to positive change. That was a little different than prior year, and the issue of teamwork, support of the team on the unit, and respect were issues that were drawn throughout the different surveys in the areas that were evaluated by our staff. They found that supervisors did support them and had recognition of work done using patient safety procedures, and they felt like that they, in their unit, specifically by their supervisor, that their suggestions were heard. So overall, that was really some positive outcomes from the survey. We found that we still had some opportunities though, and I don't think this will surprise you guys at all. You're in our facilities and you see this routinely. But there was a perception as to whether or not we had enough staff to handle the workload. Really mixed reviews there. Staff perception that their mistakes are kept in their personnel file is still in the culture itself. And their ability to question the decisions of those over them. So, specifically in the layers of supervision, that they perceive their ability to question things as maybe not so welcome for those with more authority. Hospital unit coordination or coordination across the units historically have had this same finding, but it was consistent in this year, which is they just feel like things fall between the cracks when a patient is transferred from one unit to another, or that there is not communication between all the parties taking care of the patient, and that perception that important care information is lost during shift changes. So all of that really ties back to the handoff communication that we talked about earlier. We still know we need to work on that. Nursing leadership has still taken on handoff communication as an area where they really want to focus and how they may be able to improve that for the patients that we care for. I just entered some of the questions that were on this to give you some idea of the spread of the staff that actually answered the questions. Overall grade on patient safety, we came out ahead, I think, this year. We had either very good or excellent as the leading outcomes, with acceptable being kind of the midstream. Not very many poor or failing, but we still had some. So it indicates that we still have pockets to work on there. When we got into tenure, this was where some of this began to be a little interesting to me. We know we have a lot of staff that are brand new, a lot of new students that have signed on with us on different units. So look at the spread, 1 to 5 years or less than a year. It's now our leading numbers for our organization. And at Baptist, we have a lot of people that have been here a very long time, but that number is dwindling if you look at the spread on our patient safety survey. When we asked how long they worked in the current hospital work unit, that also was telling that they were either new to their job as a healthcare professional or they were new to their unit. And so the fact that we had so much positive things to say about unit-specific teamwork and respect was really a very good thing. Our fourth goal was really to increase physician leadership participation and actually set champions for patient safety program elements. I'm a firm believer that if you're going to have change that stands the test of time, you have to have physicians at the helm. They have to believe in what those initiatives are, and they have to model that behavior if our staff are to continue to see those things going forward. There we go. We have physician engagement in our patient safety committees. The committees are actually in every facility, and we have a system committee as well. The administrator co-chairs it with the patient safety officer in my department, And then we have interdisciplinary teams from all different disciplines in there that participate. We have very active participation in Little Rock and some of our rural facilities. So we are seeing that grow and develop as everyone understands what our initiatives are and what we're trying to accomplish. We also have some very good leaders in places where we've focused in on PSI initiatives. One of the ones that I use for an example is Dr. Overacre with the post-operative procedure, respiratory failures, and what we learned from that, that's a united team of coding, medical records, quality, risk management, and 3 physicians that review those cases. And we try to determine why these patients fell out into these indicator buckets. Sometimes it has to do with documentation and how we identify intubation post-procedure. So not every time a patient is intubated post-procedure is a respiratory failure, and having physicians document specifically as to why they're supporting the patient in that way will help coding make sure that they're not picking it up as a respiratory failure. I've told you a little bit about the FMEA or the green belt that we're working on for surgical cancellations. And then we also are trying to align with BHPP in a reduction in variation of practice, improvement of care. So surgical cancellation is one that really interests BHPP because it will impact a certain number of physicians as well as our patient population. And then we've had physicians lead CEAs for event assessment and corrective action. There's one that'll go before our Assistant Patient Safety Committee in this next quarter, where Dr. Harder and the team in one of the procedure areas worked on a situation where we had a patient on anticoagulants have some complications post-procedure. And so they developed a lot of some very good positive initiatives to go alongside the wrong site surgery policy, which basically is the site verification and medication evaluation in that area. There's a banner that specifically identifies patients on anticoagulants, and so that doesn't just help them, it helps other procedure areas or units as well. So that was a really good addition to their system of the the pre-surgery assessment. We're really trying to reduce harm and severity in those areas where we have procedures or surgery. As you might well expect, that's kind of the areas where we have a number of our moderate, severe, and harm cases, because that's where we do invasive procedures. So that's really why we chose that. One of the things that we did with the Clinical Advisory Committee, Dr. Phillips specifically, is they did a revision for the wrong site surgery prevention, which was fully directed by clinical affairs and physician driven. That has since gone through the proper committees and been evaluated appropriately. We also are looking at informed consent and patient education product that might be very beneficial for our ambulatory and inpatient physicians for their patient education. We already use a product called Elsevier for the training elements or the written education that's within Epic. And this product actually is the video portion, which would allow us to deliver education and video directly to the patient on their own device from any of our areas of practice. So really neat opportunity there. We can modify it, and it's very flexible, so it can be branded for Baptist. And we're in the later stages of that as well. We've had everything evaluated through the Clinical Affairs Committee, and this particular product by Elsevier with the tonic application is going to allow us to provide informed consent documents and education prior to procedure. So that'll be a great add. I wanted to give you guys, because results really matter, right? And so all of this means nothing if we're not going anywhere. We have accomplished some great things in the last 6 months. We literally started in November of 16 and pounded out what the structure of our patient safety program should look like if it were operating effectively and making change occur within our organization. So we've been through 2 total quarters of work in all of the different facilities. And as a result of that, we were able to produce in the second quarter a report to our system patient safety committee, some 4 key projects that actually had the reach across the organization to all the areas where this might occur. The first project had to do with aspiration precautions, and I really just need to stop here and give credit to the teams that worked. Again, I just want to make mention that this is not my team in risk management. It's actually an interdisciplinary team made up of occupational therapists and physicians and nurses that take care of these patients on a routine basis. But in this particular project, we had a situation where the swallowing function was assessed by a speech and language pathologist. And the process for documentation and communication of the results when the patient fails the exam was inconsistent within and among the facilities, causing gaps in care for our patients. We received a quacker on the patient who had failed a swallowing evaluation post-extubation with prolonged mechanical ventilation, and the recommendation from dietary was to keep the patient in PO. The surgeon ordered a diet which was provided to the patient that resulted in aspiration and reintubation of the patient. We determined in our patient safety committee the concern for effective communication between the pathologist and the surgeon and nurses, and felt that the harm level was moderate and could almost certainly have been prevented. So the assessment was brought to the system clinical analyst and EPIC nursing champion that worked with the clinical staff to redefine the process. In the end of this, the patient can be marked difficulty swallowing if applicable, and it'll fire the swallowing precautions banner. Diet or MPO order is entered with the physician's signature required, and the progress note enters staffing OPV results and recommendations. If appropriate, the swallowing precautions sign will be posted in the patient's room, and aspiration swallow precautions are entered. And then we inform the patient, family, and nursing of the results and recommendation, and we put a blue clip on the patient's armband. So all of these things happen specifically with the assessment, and the recommendations were that EPIC build would be completed, and it has, and a clearly defined process now is in place. So we're looking to monitor that and get information back so that we know that that has actually been effective. The second one had to do with alarm management for medication alerts, and in this situation, we have thousands of warnings built into EPIC that address drug disease and drug-drug interactions, duplicate therapy and doses. The warnings are so common that we clinically overlook them or override them so that when the ordering, verification, and administration processes occur, we can proceed. In this particular case, the background is that one patient's prior to admission medication was transcribed with a 10-fold error in the dose. The physician overrode the alert in EPIC and prescribed the incorrect dose. The pharmacist verified the medication and dose after also overriding the alert. Nurse administered the medication, overriding the alerts, and the patient was given the medication twice daily for 4 days, 10 pills each time, resulting in an altered mental status and falls. We actually said this was also moderate and could almost certainly have been prevented. We found that the medications that were built into EPIC, those alerts that address our medications, were implemented without an extensive evaluation of what they actually did for our clinical staff. And the number of alerts for a 10-day period when assessed by the interdisciplinary team was over 10,000. There were warnings which added absolutely no value at all for patient safety. For example, an alert regarding a pregnancy status appeared on the patients who are not even pregnant. So if you're pregnant one time, that medication alert is there for life. We measured that just in the Little Rock and North Little Rock 10-day period, and we had 336 alerts. We looked at them by type, and we also looked at them specifically by whether or not they were overridden or removed, and how many of those alerts were severe or contraindicated alerts. So our recommendation really was to eliminate key priorities, eliminate the pregnant for life warnings or duplicate therapy warnings for pain treatment, stream and facilitate the process of end-user filtered warnings for like our physicians, and review all new BSA requests. That's supposed to be BPA, forgive me. Actions that we already took were to suppress the duplicate therapy warnings for PRN orders with different PRN reasons, and suppress high-dose warnings for the 5, 10, and 15-minute PRN pain orders. And so you can see there that we've taken a number of steps just to limit those and try to reduce the number for alert fatigue issues that are happening across the organization that are allowing these medication errors to occur. The third one we had to do with a malfunction of our equipment at MedFlight. And in this particular case, we were actually transferring a patient from a trauma situation to our ER. And when they arrived, we found that the tube was actually in the esophagus. So when we reviewed the case, we actually found that there was a failure in one of the pieces of equipment, and the backup monitor did not measure the end-tidal CO2. So we had to re-intubate the patient. There was very minor issues related to that. However, we felt like it was likely preventable. We weren't really sure that we could find the exact cause of the esophageal intubation. There was a difficulty transferring the patient into the helicopter at the time of the flight, so there was like a slip and a jar to the patient. We felt like that might have contributed to the displacement, but there were also some additional findings that we addressed in the assessment, and a number of recommendations that came as a result of that. There were some duplication and one med with different names that they were utilizing. So we just went through each of the processes related to equipment, medication administration, and documentation to try to correct some of the things that we saw. We provided also kind of a process map, and then also an out of service. This is actually supposed to be yellow, but I tried to change the color so it was a little bit more fall related, and I think it changed the color of the sign. But in this case, they were able to put that on their equipment and hold that for the TriMedics group to pick up and evaluate. This final project, I think, is one of the most exciting. I don't know if you've seen this in the organization as of yet, but we found that there was one specific patient event, but there had been a trend of things related to DKA. And what we found was there was not a set protocol for insulin after the DKA management was complete. So what we did is we identified the absence of the DKA order set, and we worked to align evidence-based practice for the correction of DKA. We also identified some knowledge deficits specific to the two types of diabetes that we have. And we also identified improper transition from acute management to general management of type 1 and type 2 diabetes. We had pharmacy, diabetic education, nursing all work together on this, and it was really pretty special what they ended up with. We had multiple quackers, as I said, with a harm level of moderate and almost or likely preventable that had come from them. And most of these patients had a reoccurrence of DKA for failure to monitor and treat diabetes post-DKA monitoring. So the team got together and collaborated on the DKA order set, and that team identified several of those issues that are found there. Basal insulin wasn't ordered. We didn't have orders to change the NPO status as the patient improved. Orders to adjust base IV fluids and potassium were very confusing, and no warning to withhold insulin until potassium was greater than 3.3. So the recommendation was that the DKA order set was revised to include the following changes, and you can see there that they provided an algorithm that was created and linked throughout the DKA order set to help determine IV fluid changes and potassium supplements based upon the electrolyte results. And it was, the potassium replacement protocol was updated so that it was seen with the DKA. I'll show you here how you can see there the transition to subcutaneous insulin order set was created, and there's the algorithm that is within Epic at this time. We also addressed the treatment of hypoglycemia with this particular finding. The Epic team built this into our system. So what we have really tried to do is make sure that everybody understands that the patient is our purpose. We're out there to try to make things better for them in all tasks, duties, and actions, that should be our priority. Patient safety is so key and critical to everything that we do, and it's not limited to one department or one person. It really takes all of us doing our part to identify those things that create opportunity for error and harm to our patients. So I really appreciate the opportunity to come and share those with you. There's been some really good outcomes, and a lot of that has to do with the fact that we've had so much participation across the system to make this work this year. And I really think that in 2018 we're going to have some great things happen as a result of our work this year in patient safety. Thank you. Are there any questions?
I have a brief, quick question. So on one of your scenarios, the esophagus was intubated. How does that end up being minor?
Well, in this situation, it wasn't a full intubation, so the harm that came to the patient was not a prolonged period of hypoxia. So the patient, even though we didn't have a full intubation,